And then I'm going to turn it over to the stars of tonight's show, who are basically half, maybe more than half, of ASMC's non-operative sports medicine team. So they're going to tell you a little bit about what they do and what patients might be able to benefit from their help. So we've got Dr. Ratliff, Dr. Koistinen, and Dr. Tramatullo. I did it, Tramatullo. And I'm going to turn it over to you guys. Thank you.
All right, cool. Well, like she said, we're part of Arizona Sports Medicine Center. Tim Ratliff, Brendan Koistinen, Cenk Tramatullo. We are the West Valley faction per se, with a little bit of Central Phoenix mixed in as well. So I'm in our Arrowhead and Goodyear clinic. Brendan is in our Goodyear and Biltmore clinic, and Jake is in our Verrado and Biltmore clinic. So scattered across the entire West Valley, we are your guys to try and help you out. With that said, if you guys are cool with it, we'll just jump in. I have a quick talk about basically what we see, what we offer, and then Brendan's going to dive into a little bit more of a detailed thing about one of the things we're going to talk about, and then hopefully you guys get a better understanding of what we do and then how it can relate to you guys, and then we go from there. So sound like a plan? All right, so bear with me. Like I said, we're with Arizona Sports Medicine Center. We also obviously have East Valley locations. They are in our Scottsdale office and also our Mesa office. I think those are the two East Valley locations. Yeah, and so they're the East Valley folks. All right, so the ultimate goal of this is we see the non-operative people, or we see the people that the primary care doctors are like, I have joint pain, go see somebody. And the famous word that most of us get are, we're not interested in surgery, or what can you do that is not surgery, or what are the options? And the entire point of this talk is to try and walk through those options that we talk about every single day, and then try and help patients to stay away from the OR as we see fit. So what are these treatments? A lot of the times, and this is not an all-inclusive list, I get that, but these are kind of the highlights that when you have patients come into your office like, Dr. So-and-so did this to me, you know, hopefully these are the main ones you're hearing about. So obviously everyone's heard of a steroid shot. You probably have patients every day showing up with steroid shots. Maybe they have visco supplementation or hyaluronic acid injections, same thing, but those are typically for arthritic joints that just help to improve joint lubrication or also help with joint pain. PRP, platelet-rich plasma, that is the popular kid on the block right now. You listen to enough of the radio, you're going to hear wonderful ads on the radio about regenerative medicine and everything. And then prolotherapy, another type of treatment, and microvascular tissue allograft injections, those are kind of newer. Also the stem cells that are out there. There's bone marrow aspirate concentrate injections, there's amniotic tissue injections, and there's also adipose tissue injections. So those are kind of the biggies. Basically, how do these all work? So steroid shots, again, steroids are the bread and butter of pain relieving shots. They act directly on the steroid receptors, they interrupt inflammatory markers. They basically, as I tell patients, and everyone probably has their own way of telling it, they are the ones that try and put out the fire. You have pain, this is what we give to try and help. Typically, clinically, they decrease the pain, the swelling, the heat, the tenderness of the joint. Essentially try and just make the joint feel better, but it also comes with some negatives. They are not the healthiest for the joint. You've probably run into patients these days that are talking about, I don't want steroid. I've read something, I heard something, they're not healthy for my joint. That is something where, yes, we know that they're not the healthiest, but we kind of walk through them with it as we do them. Common uses, arthritis, tendonitis, bursitis. Again, we got to be careful. They can be a little bit bad for the joint. They can thin the skin, they can eat at cartilage, but we try not to do them more recent or more sooner. I can't even talk right now, but more frequent, thank you, end of the day, but more frequently than every 3 months. So if you get that patient that is just coming, hey, I need another shot, another shot, another shot, that's where we start looking for other options. Visco supplementation. This is the rooster comb shot, the gel shot, hyaluronic acid, the lubricating shot, the oil change shot. I'm trying to think of every way your patient might say it. But this is a pretty common one that we do very often. So what is hyaluronic acid? It's a naturally occurring protein and a component of synovial fluid. Basically, it gets in there and it tries to just help spruce up the joint. I tell folks it helps to thicken your joint fluid. It helps to just try and fortify your cartilage a little bit. The analogy I use is it's like an oil change of your car. It tries to help protect and preserve the engine, but it's not really gonna fix anything. We don't have evidence that says it necessarily is gonna make it, fix that cartilage or heal that cartilage. And in our osteoarthritic joint, both the molecular weight and the concentration of hyaluronic acid are decreased, so that's why these are a supplementation shot. We are just adding that back in. Basically comes from a variety of sources, and again, it is just a shot that we like to do. You can do them every 6 months, insurance willing. Insurance will only cover it for the knee, so if you have patients that are asking, can they put Visco in this, that, or whatever, knees are the only ones insurance will cover it. Some insurances won't cover it at all, so it all depends on authorizations, things like that. We all inject them into different joints. It just then becomes a cash pay injection. Hips, shoulders, done it in finger joints, you name it, we've put it there. But it gets a little bit more tricky with that. So at least from the common aspect of what you guys will see, visco supplementation, knee joints, arthritic joints. If your patient asks you, hey, can you put it into shoulder, like rotator cuff, things like that, I think I've
had a few hips get covered.
Yeah, a few hips have been covered.
Probably not correctly, but yes.
Yeah. But then I think like Dr. Rich, he's done hyaluronic acid into like rotator cuff tears. I don't really have much evidence on that, but sometimes those patients find benefit as well. Again, most common use of it, arthritis. The side effects or the cons of it, it requires insurance approval. These are very expensive injections. They are not cheap. We're talking $1,500, $3,000 for a series of 3. So we like to have insurance coverage for it. That can typically be a hindrance to sometimes the patient receiving it. And again, covered in the knee, some hips, but that's a big one as well. PRP, so now we're getting more into the cash pay realm of what we do. PRP basically promotes healing by utilizing the growth factors in the blood. We draw blood, we spin out the unnecessary products of the blood, the red blood cells, other aspects of it, leaves us with a protein or platelet-rich plasma. Gosh, I'm talking, I promise. The idea behind it tries to improve pain and function wherever you inject it. Can put it into joints, can put it into tendons, can put it into strained muscles, you name it. We can put PRP pretty much anywhere. We can do it for hair growth, you name it, it's there. We don't do it for hair growth, but you can. Common uses again, arthritis, tendonitis, bursitis. With PRP, you guys will see a lot of post-PRP injections. Patients might come in, man, it hurts more than it did before I got the shot. The whole idea is we are creating that inflammatory response to try and create that healing reaction. Typically when I do a PRP injection, I tell folks, hey, that first week it might hurt more than it hurt, but again, that's just that inflammatory response. We try not to ice, we try not to do anti-inflammatories after immediately the shot. And then that's where we kick them over to you guys after the week or 2 to start building things back up. Prolotherapy, I do not do prolotherapy. Jake has done prolotherapy. Prolotherapy, he can probably correct me on this a little bit, but essentially It's an injection of an irritant solution into joints, tendons, or ligaments to try and spur an inflammatory response. We are talking cash pay. Typically, it's like a dextrose type solution. You mix it in with saline, you find an area, you just inject it. Idea, you're causing an irritation. Basically, your body sees it, tries to send an inflammatory reaction to it. Good summary of it?
Correct.
Correct. Cash pay. Cheap. It's another option out there. Again, Jake could probably be our Prolo guy if he wanted to ever do it. So let's see here. Compare, contrast the things. So who gets what? Again, steroids, fast acting, they can last weeks to months. Everyone responds differently to steroids. I tell folks could be 3 hours, 3 days, 3 weeks, 3 months, 3 years. Everyone's different. Just because your best friend's aunt's sister's daughter had a steroid shot last 10 years doesn't necessarily mean it's going to happen for you. Yours might only last a few weeks, few months, you name it. Again, with steroids, the biggest thing is we try not to do them more frequently than those 3 months just because of the negative effects of steroids. Visco supplementation, those can take a little bit. There's 1-shot formulations, there's 3-shot formulations, there's even 5-shot formulations out there. At that point, you're just torturing people, but there's still some brands that do those. Those typically take weeks to kind of kick into act. Sometimes people come in, wow, I feel amazing after the first shot. You just nod your head and say, wonderful. But I always say, hey, don't give up on it, even after we finish either the first or the third one. You know, it might take a few weeks to kick in. Again, those are about every 6 months, and that's an insurance determined number, but 6 months is what we're striving for. PRP, again, can take some time to really start acting. I always tell folks that first 3 weeks after the shot, if it doesn't feel like you've noticed anything or it's improving, that's okay. We're not giving up on it. Basically, that 3 weeks to 3 months range is where we hope to see improvement. And then again, not a lot of insurance coverage out there. Not, at least in our group, it's just a straight cash pay thing. We don't take insurance coverage on it. Do you guys want to do audience involvement or just kind of crush through this? All right, so what do you think? We got a 65-year-old female with moderate bilateral knee arthritis coming in with sporadic pain. Mainly just hurts with activity, but most of the time she's feeling good, but she's trying to hike or do this. What do you think treatment-wise our end is looking for? Visco, yeah. So it's not hurting her every day. It's not hindering her ability to live. She is, happy to do whatever, but man, it just kind of barks at me at times. Perfect candidate for visco supplementation. 47-year-old male with mild arthritis comes in with severe pain, leaving for a cruise in 5 days. Oh my God, my trip's going to be ruined. We don't have these patients ever come through our office, but what is maybe indicated in that situation? Steroid, yeah. Hey, quick fix. Hopefully this gets you through your cruise, maybe in a little longer, and then we can figure out where to go from there. 17-year-old high schooler, right medial elbow pain, felt a pop while pitching. We got an MRI, shows a partial UCL tear. Steroid, right? No, good. This is typically one, yes, I understand physical therapy, we're getting there, but also probably one that is indicated, if we could say that for PRP, definitely something we'd have a conversation for. That partial UCL tear, young kid, we want to try and avoid steroids. He'd be a great candidate for PRP, especially with the partial tear, plus physical therapy. 12-year-old, I don't know, do you guys see kiddos, 12-year-olds lower? So every 12-year-old is a great historian, right? They just come in and tell you everything, don't look at mom or dad or, whatever. But 12-year-old with some knee pain, poor historian, what do you think we want to do? Nothing, kind of nothing. Maybe some Tylenol, maybe ice, maybe have mom or dad kind of watch them, see how they're doing. There could be a lot going on there. I realize that's a loaded prompt right there, but a lot of times for at least us, it's just, hey, let's just see how they're doing. Maybe some Tylenol, maybe some ice, stretching, catch them doing whatever they're doing. And then We also never see these, but 75-year-old female, lateral elbow pain, playing just a few hours of pickleball a week. She plays 5 hours a day, 6 days a week, never rests. What would you recommend for her? Rest. And physical therapy, right? Yeah, what else is out there? So Brendan's going to talk about this first one in more in-depth, percutaneous tenotomy, so I'm just going to leave that for him to talk about. There's also shockwave. Do you guys have shockwave in your clinics? Not yet. So shockwave and then physical therapy. That's Brendan's talk. So then shockwave, non-surgical treatment, uses acoustic shockwaves to try and treat pain and promote healing. Essentially device, put it on there, percusses the skin, sends shockwave or sends acoustic waves, tries to promote a healing response. Cash pay again, typically about a 3 visit series to get them back into the clinic. Again, this is one that, you know, maybe you've tried too many steroid injections, or maybe you've tried physical therapy and you're not getting anywhere, or maybe you've tried PRP, or maybe they're not financially able to do PRP, or a lot of different things. Just another option that we have in our office that we could do and then kind of kick them back to you guys to continue to work on physical therapy. Common uses tendonitis, bursitis. Again, the negatives or the cons: cash pay, temporary pain, swelling, bruising, because it is a little device that can percuss on their skin. Lastly, I don't think you guys need a slide for me to read to you about this, but we utilize physical therapy. What I talk about every single time that I give these talks is you guys are our #1 like rock stars when we send you a patient. I cannot express how many times, and they can probably say this as well, hey, I think you really need physical therapy, and the first response back, I've been to physical therapy, it doesn't work. And it's like, yeah. And then it's like, why didn't it work? Oh, they weren't paying attention to me, or they sent me off to do this and never checked on me, or they just didn't, you know, work with me, or blah, blah. We all know the answers, right? So when I like to say is, we are here because we like you guys. We trust you guys. We want to work with you guys. We know you guys are all wonderful therapists. The #1 thing that I can say is when we send patients to Spooner, when they come back and they say, you know, wow, physical therapy, I've never had that like that before, or they actually worked with me, or it's like, yeah, and look, you're doing better. So obviously physical therapy, we utilize you guys as an extension of us. We get them for 15 minutes or 20 minutes as a snapshot. Hey, this is what we think, go do this. You guys are the boots on the ground to try and help heal, and then your work sometimes, or most of the time, actually makes us look better, because they're like, wow, you guys just, you knew exactly what we needed, I needed that, and it's like, you're welcome. Like, and then kudos to you guys. So obviously physical therapy, you guys are our best friends here. And then, I mean, again, you don't need me to tell you that. So I put my cell phone number up here. Obviously, before we leave, take down all of our cell phone numbers, because again, we are in the West Valley. I can say this for all of us, text us. If you have a patient, you need us, just text us directly. I will never be upset if you text me and say, hey, I got someone, can you see them XYZ? It'll be like, yeah, you know, and then we'll get you right in, kind of thing. So that's mine. Is your cell phone on your slides?
Yep.
Okay, and then
I'll give mine.
we'll get Jake's at the end. So any questions, concerns, anything like that? Hopefully that's just a general overview, not too boring for you, but thank you guys. So.
Kind of non-specifically for common extensor tendinopathy is just kind of a pretty generic one that we all see pretty often. This is going to have no disclosures. This is about me a little bit. So I'm from South Dakota. I went to undergraduate in South Dakota. I played baseball, so that's my background. I went to med school here at Midwestern, and then I did my residency training at the University of Florida. So I'm a Gator, and fellowship I did at Andrews Sports Medicine in Birmingham, Alabama. Got a lot of my sports specific on-field, training, doing that. So I was one of the physicians for Troy University. We won a bowl game. I have a nice ring. So if anyone's ever in my office, they've seen it. Yeah, Christian's seen it. Did some other stuff too, other sports, all that type of stuff. So, all right. So sports medicine, I started here at ASMC in September of 23. Basically is kind of, Tim already talked about this, but non-operative, proceduralist, non-surgical, that type of stuff. For me, I do everything basically except the back. So knee, shoulder, hip, hand, ankle, foot, whatever. Like I said, specialty, if you had to pick something, ultrasound guided procedures. So Tim talked a lot about the things that will inject, but you can use ultrasound for many other things. So diagnostics, interventional procedures, specifically this percutaneous stenotomy. I do something called iovera. It's a kind of temporary nerve block. So a lot of different things that you can use ultrasound for, which is kind of our differentiator. And then, yeah, we talked about our locations already. So let's just get into it. So tendinopathy, we all kind of know what that is. So it's a disease state of a tendon. So characterized by pain, decreased function, and then that can cause significant disability. So usually in our active patients or overusers, that type of thing. So normal tendon, it's kind of that nice stretchy force transfer. It's normally white and firm, but with kind of an elastic texture. When you get tendinosis, you get a thickened, gray, kind of swollen, less functional tendon, and therefore that can hurt. It has disorganized collagen, loose texture, and then neovascularization. So these are a couple ultrasound scans of my elbow. No, this is not my elbow. These are irregular elbows. So when we look at ultrasound, a normal tendon will look like this. So nice, straight fibers. Abnormal tendon up here, you've got hypoechoic or kind of, increased fluid signal or changes to the tendon. And then neovascularization, that just means that there's infiltrating blood vessels that are kind of feeding into the irregular tissue. So we'll put the Doppler on the ultrasound and then we'll see all this kind of, blood flow basically into the tendon, which normally you should not see. All right, these are a couple shots of my beautiful elbows. So common extensor tendon here attaching to lateral epicondyle, both sides. For the most part, mine looked pretty good. I had a little tennis elbow 10 years ago, but they look fine now. All right, so how does it happen? How do we get into this diseased state? So usually what happens kind of initially, there's an injury. So whether that's acute injury, overuse injury, those types of things. So the normal tendon will become inflamed, which is our classic tendinitis. So warmth, acute pain, swelling, all those types of things. And then basically your body kind of has a dysfunctional response. So normally you have cytokines and all these immunomodulating factors that are going to facilitate repairing that tendon back to normal, but for whatever reason there's this irregular response. And so what happens is you get this kind of fibrotic, disorganized tendon. Instead of it coming back together nicely, it's kind of, disorganized. A failed healing response. There are some risk factors for this, specifically age, smoking are big ones. Other things you'll see more often in people who do the repetitive occupations, so contractors, throwers, that type of thing. And then usually kind of, especially for you guys, there's some sort of kind of biomechanical, increased load due to poor biomechanics that is putting more kind of load onto a tendon. So treatments, what do we do for tendinosis? So initially, conservative treatments are definitely our preferred. So relative rest, activity modification, pain medications, bracing, straps, different modalities, therapeutic exercise, physical therapy. So most of the time that's effective. That's what works. But up to 20% of patients can then fail to respond. So then we get into what do we do for these patients who have failed their kind of initial treatment plan. So shockwave, we talked about that a little bit. Some pretty good evidence for using it for tendinosis. Cortisone, maybe, maybe not. So we've talked about what is tendinosis. It's a disorganized tendon. It's not an acutely inflamed tendon anymore. Steroid shots or cortisone shots are for inflammation. So in theory, that doesn't even work, right? So a lot of patients will have a short-term response, but really not a lasting or impactful response. And then we talked about their side effects, hypopigmentation, atrophy, they can raise your blood sugars, all that type of stuff. PRP, technically investigational, seem to help most of the time, but not all the time. Does it get into the tendon if it's scarred and thickened? If you're injecting it into the tendon, I don't know, we don't know. So that's where we get to what else is out there. So kind of going back to the basics. So if a tendinosis is a disorganized, improperly healed tendon, how do we then get it back to normal? So that's where this comes in. So percutaneous needle tenotomy, it is a microsurgical tendon debridement or fenestration. There's a bunch of different kind of like acronyms for it, but basically it's microneedling of the tendon. So this involves passing a needle through the area of diseased tendon to disrupt those irregular fibers and kind of reset them back to normal, to then promote a new inflammatory response to lay down normal tendon. So trying to break up the bad tendon, let the new tendon kind of fall in place. So devices. Initially, 30, 40 years ago, this was done just simple needle fenestration, so just take a needle and just kind of, break it up, right? Now, that's kind of barbaric and also not very effective. There's different devices that accomplish this goal in different ways. So 10X, 10Jet, Tendinova, these are all just different devices. For me, I have experience with 10X and Tendinova. I think you did 10Jet and before, and Tendinova, and then I think Tim did 10X as well. So all these different devices, they all have their different ways of working, but the same goal of breaking up disorganized tendon to try to then allow it to heal itself. All right, this is just specifically Tendinova. I don't know, I added that because it's like the newest one, and it's kind of one that our clinic got. So this is a minimally invasive mechanical tendon fragmentation device. 10Jet uses like high pressurized water, and 10X uses kind of acoustic vibratory cutting techniques. So this one is more of a mechanical true cutting needle. So it is a portable device. It's got a little battery pack and then this kind of sheath that you hook on with a needle. It's an 18 gauge needle, so it's just kind of like a basically slightly larger than the normal injection needle. But inside of it, there is a 22 gauge cutting needle, which you can't really see in this poor image, but that little thing pops out and it's got like a cutting tip on the end. And there's some kind of like things describing, the hertz and all that type of stuff. So for this, it's newer. It was actually made by, or kind of constructed by guys who do what we do in Atlanta a couple years ago. I've met him, he's a pretty cool guy, but basically they wanted a different device that is cheaper to make and cheaper to use than say like 10X or 10Jet. So there's really no peer-reviewed studies. They did a clinical study where they studied, and I can't remember, it was like 20, 25 patients, and 87% had improved pain, good outcomes, etc. One of the cool things about this is it can be used in conjunction with PRP. So we were talking about tendinosis, does PRP even get into the tendon? Well, here you can kind of create a hole in the tendon or break up the diseased tissue, and then what you simply do is you just unscrew this white thing, and then you screw your PRP syringe onto there, and you can inject PRP right there. So that's kind of cool. About this, so 10X and, I don't know, does 10Jet break up calcium buildup pretty well? Decently? Okay. So 10X, 10Jet are good for calcific tendonitis when you have big calcium balls in the tendon. This does not. This does not have enough force to break up calcium deposits. It is very good for diseased tendon, but calcific tendonitis, this is not your choice. And then post-procedure, this is just their provided kind of post-procedure rehab plan. I'm sure you all have different kind of post-tendinosis treatment, rehab plans. I'll back up. So usually a couple days, 3 to 5 days of just kind of limited use, and then passive range of motion for about a week or two, and then gradually progressing from there. It's kind of a shortened, quickened rehab process. So as I said, Tendinova does not have any currently published studies. They did some animal studies. Basically, they took rat Achilles, I think, and rabbit Achilles, and they studied it. It got better. The human pilot had 15 out of the 18 were improved at 90 days, 75% excellent results. So more background. So many studies in the past 10 years on 10X, 10Jet needle tenotomy, open tenotomy. Generally, all of them have improvement in pain scores, improvement in function. It's just getting down to, we can now do what required open tenotomy with percutaneous devices using needles. So less invasive, less post-operative, infections, healing, all that type of stuff. Yeah, all this other stuff it works pretty well. So summary, there's numerous low-quality studies that suggest percutaneous tenotomy offers promising option for refractory tendinosis. Outcomes are similar or better than surgery and PRP. So pain scores improve in weeks, recovery proceeds over months, and long-term outcomes are favorable. So there's some sources, and there's my cell phone number. All right. Questions?
What tendons do you usually use?
Most. I'll tell you lateral elbow, glute, and some cuff stuff. Patellar tendons, Achilles, plantar fascia are other indications for it. I haven't used it as much for those, but definitely lateral elbow, lateral hip. Yeah.
Anything specific that our therapist should be looking for post tendinova if we're seeing them in the clinic? Any adverse reactions or anything that you want to know about ASAP?
Yeah, so obviously anything concerning about the incision, it's literally a needle poke. With 10X, there's going to be saline that's used, and so sometimes it can kind of like weep and stuff like that. But obviously, any concerning infection signs, most patients post-procedure really can be managed with just Tylenol. So largely, they're going to be sore. It's going to be somewhat painful afterwards. It is a real procedure, but obviously, pain out of proportion. Send us a text. Just let us know. We usually follow up 2 weeks post-op.
Are there any contraindications to using it for joint replacements down the line?
Not that I know of, because you're technically extra-articular for all these tendons. So some hip replacements, you do them for lateral hip, that type of stuff. So it's not as far as I know.
Are you generally doing those after a course of surgery management?
Yeah, usually for me, my protocol would be see the patient, seems like tendinosis or tendinitis, send them to PT, do anti-inflammatories or cortisone shot. They come back 6 weeks to 3 months, somewhere in there. Are they getting better? Are they not? At least have the discussion that this is available, maybe send them back to PT. But yeah, usually always go through the kind of normal type of stuff. Except for if they come in, their rotator cuff has a calcium ball like that, well, okay, maybe we'll jump the line on that one. But yes, regular tendinosis, tendinitis, always kind of go through the normal stuff. Because like I said, 80% of people just get better, so.
But if we're not seeing that improvement in the 6 to 12 week range,
Yeah.
that would be a good time to refer a patient to you guys.
Yep. Usually then I'll send for an MRI, make sure nothing is out of whack. There's no large, huge full thickness tears, all that type of stuff. And then, yes.
Could this be applied to proximal hamstring calcifications?
Yep. I don't have much experience with that, but yes, it does. And we do have 2 people in our group that have done it for that type of stuff. Yep.
The definition of a partial tear,
Definition?
how big is it? How much is it?
Yeah. I mean, right there, that little black stuff right there, that'd be a partial thickness tear. I don't know, that's probably 20, 30%, something like that. But technically
What percentage does it become?
There's no standard. It's,
Yeah.
As long as it's not full,
Yeah.
it's partial.
As long as it's not full, retracted,
So
yeah.
It's either full, partial, or complete?
Yeah, so complete would be full. So full thickness, complete, rupture, kind of we all use for a complete disruption from
This is not going to help that. It is no longer attached. But partial thickness and stuff, yeah, you could do that for some of that.
Because you see it on findings
Reports and stuff, yeah.
Could be 10%.
Yeah.
Yeah,
Yeah.
that's what I'm saying. Because we grade these a little bit, so we
Yeah.
know how hard to also push them.
Yeah.
I certainly find myself being far less aggressive if it looks near full thickness.
Oh, yeah,
near
yeah.
Complete. We use clinical judgment a little bit.
And that's where we may bring in our PRP or one of our other tools
There's no grade between 25 and 55 or 75.
No
I feel
grading.
like they should grade those. Feels like that should be.
There's probably a grading system. I mean, there's always a grading system and there's always other grading systems for that same thing.